So, as we have already talked, cornea is not a perfect camera. The eye works only at 40% efficiency as compared to an ideal camera, which works at 100% efficiency. The rest of the 60% is aberrated, partly by the optical system of the eye. So, all these are neutralized by the neural processing of the retina, optic nerve, and brain. So that's how we get a very clear picture. The picture formed on retina is very crude, for which Hubel and Wiesel got Nobel Prize way back in 1963. If you see that picture, it's very crude, hardly recognizable. So as she has already highlighted, eye aberrations are total corneal as well as internal optics of the eye contributes to it, and measuring corneal aberration without lens or total aberration is, doesn't mean anything. And we all know that it can be higher order aberration can be classified into Zernike polynomials, but the clinically relevant aberrations are comma and spherical aberration, which we are able to address as of now in the lenses. And lower order aberrations accounts for around 18 to 80 to 90% of the optical defects. Rest of the aberrations, these are the lower order aberrations, and higher order aberrations accounts for around 10 to 20 degree of optical aberrations. There are polynomials which goes up to 64 types of aberrations, but we are mainly concerned with the third and fourth order. Rest of it is, as of now, is noise in the machine. Our machines are not sensitive enough to detect those, and as of now we are addressing only spherical aberration and comma aberration to some extent with few lenses. So uh, okay. So, coming to the spherical aberration, you all know it is of two types, positive and negative spherical aberration. Normal eye has positive spherical aberration, cornea has positive, and the lens has negative in youth of life. As the age advances, the lens also acquire positive spherical aberration, and following a surgery, a LASIK surgery, or we introduce flattening of the cornea, you get a positive spherical aberration is increases. And spherical aberration and defocus aberration are the only aberration centered on the optical system. Rest of the aberrations are in the peripheral part of the system, and only these two have been targeted by aspheric IOLs. And this are already highlighted that young eye has positive cornea and a negative crystalline lens aberration, and the total summation is usually to the tune of around plus zero point 0.1 micron. And as we ages, the lens hardens and it changes its aberrations, the spherical one from negative to positive side, and so the total eye aberration becomes positive. This is just to show that once there is a increase in positive spherical aberration, the quality of vision goes down. And so, what is aspheric lens? So, we have to replace this positively aspheric normal human crystalline lens with a youthful crystalline lens which had a negative spherical aberration. That's how the negative aspheric lenses. There are plenty of lenses, aspheric lenses available in the market. They are aspheric neutral also. They have specific indications. So this is two eye of the same patient. In one eye, we put a non-aspheric lens, and in other eye, we put a aspheric lens, which has a asphericity of minus 0.21 micron, which is IQ lens. And you can see the Snell ratio, which is the best marker for quality of vision. In this eye, close to 1 is the best Snell ratio which we can achieve. This has only 0.09, and other eye has around 0.92, which is quite close to 0. And you can see the point spread. So again, here you can hardly recognize. Dr. Amit will be highlighting about the modulation transfer function and point spread function. So the fineness is the point, better is the modulation transfer function. So that is the difference between a non-aspheric and aspheric lenses. So spherical aberration will lead to a lot of aberration in the vision in terms of halos, glows, halos and glare, as well as difficulty in night driving. And this is the distribution of spherical aberration with age. As I already told, as we age, the negative aberration of the lens keeps on increasing towards the positive side. And as we ages around beyond 60, total spherical aberration of the eye becomes positive. And these are the various different types of IOLs which are available with different denomination of spherical aberration, and which based on the spherical aberration in the cornea, we can choose an IOL which will lead to a specific type of spherical aberration in tandem with whether we are targeting a plus or a zero or a negative postoperative spherical error. So this is a one study which highlights this. This shows that once we are targeting a defocus of 0 or minus zero point 0.5 or plus zero point 0.5, it is better to have a total ocular spherical aberration to the tune of either minus zero point 0.1 to 0 with zero diopter, or when you are targeting emetropia, or a positive spherical aberration when you are targeting myopia, and a much higher negative, because they act in tandem with the spherical aberration. Because spherical defocus and the spherical aberration, they have a summation effect when they act together, because our eye works as a whole. So this is how different types of how you choose uh, lens of a specific asphericity depending upon the corneal asphericity. That's how you can customize, because on an average corneal aberration is 0.27 micron, but there is a wide range. It varies from zero point 0.1 to zero point 0.4. So if a person is zero point 0.4 micron of positive spherical aberration, you will like to choose a IOL with much higher spherical negative spherical aberration, that is 0.27 micron minus, that is techniques. So based on that, you can choose an IOL, or depending on the target defocus you are choosing. So there are various studies in literature which tells us that using aspheric lenses increases the quality of vision. And how to go about it? So you have to evaluate the optical alignment with angle alpha, as Dr. First, this is the examination part, as Dr. Chintan has already highlighted. If there is a high angle alpha, consider a monofocal IOL. As she already told, don't try to put a multifocal IOL. If the angle alpha is not high, then we have to analyze the corneal aberration with Chang analysis, which already, and DLI, I'll come to this later on in the last talk. Dysfunctional lens index. This is a new term basically used for presbyopia. And if the aberrations are low, or if they are not low or they are high, again use monofocal. If they are lesser, and patient needs a toric, then go about a toric IOL. And if the aberrations are high, then I mean, if the angle alpha is low and patient is non-toric, you continue with multifocal or a premium IOL. So this is again a repetition of the same thing. This is a patient of cataract which is showing high internal aberration. The DLI is to the tune of 0.85. Anything less than 5 becomes an indication for doing a cataract surgery, though the angle alpha is all right. So this is the quality of vision. Corneal clarity is quite good. And this is the Chang analysis. I won't go into detail, already highlighted. And angle alpha already she has told, up to the range, up to zero point 0.3 is okay, zero point 0.3 to 5 is borderline, more than 0.5 millimeter is higher. One should not use multifocal IOL. And so this is about the modulation transfer function. Again, Dr. Amit will be highlighting this. Just to highlight this, this is an internal modulation transfer function. Because the cataract, it should be normally more than 40% at this 10 decibel. That is what the eye is efficiently working, 40% efficiency. All right. So, following the cataract surgery, this is the same patient. Following cataract surgery, now you can see the aberrations have decreased quite a lot. Already, Dr. Chintan has highlighted, and the quality of vision improves, and the DLI also improves, and the modulation transfer function also improves, the internal one, because previously it was very low. Now it's to the tune of almost 60% post operatively. That's how you read it. And again, this talking about angle alpha. Here, the angle alpha is very high, 0.71. Okay, so it's a contraindication for doing a multifocal IOL. And this is another patient where the internal DLI is not only based on the opacification of the lens, it is also based on aberration in the internal eye, like she highlighted the lenticonus patient. All right, the corneal aberration will increase in a keratoconus patient. So, if sometime even if the cornea is clear, you have internal higher order aberration. So, those are the patients we are not talking about, which are sort of in contraindication for doing a corneal based refractive surgery or even doing a ICL, because their vision will not be good enough. Uh, so here is a patient where this is the IOL selection map. It gives everything about the uh, uh, astigmatism. It tells us about whether the higher order aberrations are there or not, whether the angle alpha is within the limit. So if everything is normal and the aspherate is, it will automatically tell us which lens to use. But here the DLI was good enough. There is no indication for doing cataract surgery. So this is another patient where the angle alpha is within normal limits, and angle alpha is also okay, and there is a not very high astigmatism. Asphericity is also within, so you can go ahead with any of the premium IOL or a toric IOL, depending upon whether the astigmatism is there or not. So you can see this is the pre-op. Here we have used eye-enhanced lens. Here the pre-op spherical aberration total is very high, to the tune of 0.27. All right, and but post-operatively it has decreased too much, because here we are using a IHANS, which is a Technis platform, which has a sphericity of 0.27. That's how you improve the results in a case of given case, and you can customize the cataract surgery even in monofocals. And aspheric neutral IOLs we should be using where you are expecting some pseudo exfoliation, where the decentration of the lens is expected. Thank you so much.